Hi, I'm Debbie Cassidy. I'm the site coordinator in the Amarillo. We're at Sim Central, and I have a buddy, Mr. Guy Gilbert. He is assistant director of Sim Central, and he's videotaping this for me. Thank you, Guy. So we're working with a patient. We're going to drop an NG tube. And as an RN, I want to know, why am I putting a tube down this patient? I'm not just going to walk in and put this tube down. It's very uncomfortable. I want them to understand why I'm doing it. Most of the time we're putting NG tube down because they have a bowel obstruction, or maybe they're failure to thrive, they're not eating. Sometimes that's the best way for us to feed them. So what we do is I walk in, I introduce myself. Hi, I'm Debbie. I've been an RN for quite a little while. And so I want to know your name and your date of birth. I make sure he's up in high Fowler. And I talk to him and I tell him, hey, I'm going to put an NG tube down. It's going to go through your nose and it's going to go into your belly. And we're going to hook it to suction because you're obstructed. Sometime by doing this, I can decompress his bowel and return the bowel to normal, hopefully. If we can't get the bowel to start working again and get the obstruction out of the way, then they'll have to do surgery. So believe me, this is the best way to see if we can alleviate. Also, by doing this, sometimes people feel better. Do you have any questions for me? And I'll answer the questions. A lot of times I went up that it hurts. Yes, it's very uncomfortable. Have I had one? Yes. I always want to know if you've had one. I always tell, be very honest with your patients. Don't lose this little critter here. This is very important. That's going to be your connector. I always hang onto my connector, and I close this off because it never fails. I'll get that in, and he'll just start coming back with it. So I want to measure. Everybody's measure's different. So I'm going to go from his, I say his nose. I'll do this side.
Okay.
From his nose to his ear, I'm going to come down, and I'm going to go about our stomach's about the left side, about right here, and say, okay, so that's what that is. I can take a Sharpie and mark it, or I can put a piece of tape. They have markings on it. So I'll go, okay, I'm about right there. I understand that. And while I'm talking to him, I'm kind of moving the tube. I like to loosen mine up. Sometimes I'll put it in warm water. It's not a sterile technique because we're going into the gut. Imagine what all we eat and drink, huh? So I kind of loosen it up. I make sure I have KY. Oops, just pour that up. I have to have a piston with air. So I make sure this patient, clinical decision, does he need it? I got the right patient, I got the right procedure. I make sure I have air in my piston. I need that. KY jelly, lube this up, and I'll talk to my patient. Which nare's the best? Have you ever had a broken nose? Which one do you think is bigger? Sometimes they'll tell me I pick my nose more on the right, so it feel like it's bigger than the left. It's always amazing what your patient will confide in you with. So I lubricate it really, really good, and I tell them I normally have a cup of water if they can have a sip of water. Most patients cannot. He cannot, so I did not get him a cup of water to drink. It's better, but honestly, he can't. So what I'm going to do is I'm going to put this into your nose, and like Jenny told you, it's got a hook. So your nares go down, and I'm going to go into his, when I hit to the back, I'm going to crook it down. It's going to hit the back of his throat, and he's going to kind of fight you. Tell him to start swallowing. When he feels it in the back, to swallow, swallow, swallow. And then I will crease his head forward and help it travel down. So this is what we're going to do, and we're going to work as a team. Whatever you do, sit on your hands, don't grab me, so I don't hurt you and you don't hurt me. We're a team, okay? So I've lubricated this. I'm going to go up this nare. Maybe. And I feel the back of his throat. You hear him coughing? He's kind of, and I'm gonna move his head forward, and I'm just gonna keep working with him. Okay, guy, swallow, swallow, swallow. Give him more. Give him a minute. Okay, breathe. Here it goes. Take a swallow. Breathe, breathe. catching on. Human beings are much easier to intubate than mannequins. Just a word. Sometimes you can take your pen light and look if they honestly don't know. I've dropped a million of these. Let me see why he's not going.
Probably need a little spray.
Lubricant.
There's a pocket I noticed in the middle, so you have to go around it.
There's a pocket.
Yeah, like where it kind of comes apart.
Yeah.
You see in the nose? And rub it around with it.
Yes, ma'am. Thank you, ma'am. All right. I kind of hate to touch him.
My new gloves?
Yeah. Let's
Oh,
put-
it's okay.
I don't want to get him dirty. I wear a small.
Oh, well, I just grabbed
That's fine. I just don't want to
where I can.
get lubricant. Okay, let's try this again. So I'm going to go in. I have better lubricant now. Okay, he's choking, he's coughing. Swallow, swallow, swallow. And I'm encouraging him to swallow, swallow, swallow. And I'm looking for my mark. Okay, I got him there. Here's my mark right here. So that's about as far as this mannequin's going to take me. So if you notice, I have my stethoscope. Now pop it in my ears, and I'm hanging on to this. Hang on, buddy. I don't want you to come undone. Now put this on there. And now listen. And I hear bubbles in his gut. So, is that evidence-based? No, it's not. I'll hook him to suction, and we'll suction out. I'll take his secretions, and I'll get a pH litmus paper, and I'll test those secretions to make sure that I'm getting GI content. That is evidence-based practice. Most of the hospitals are still not doing that. We'll also do x-ray. So we'll check it with x-ray. So this is our NG. Now I have an order, and we'll take this to the nose. It has a little clamp, and it comes up, and it'll tape to the nose, and I'll pin it to his gown. I'll try to pull it back as much as possible because I don't want him messing with it and yanking on it. The other issue with the NG tube is they're moving around in the bed, and it'll have the tendency to creep out. I encourage you to check your NG tube placement. I like to go every 4 to every 6 hours and do an air bolus just to make sure I have still good placement. And I auscultate it and listen to see if I hear those air bubbles. I don't want to do an x-ray, and I don't want to pH test it, but I want to make sure we're in good. So I do that. All right, to take this out, okay, we're going to remove your NG tube. We fixed your bowel problem. So when I take it out, I get a towel, and I put a towel up underneath him, and I tell him, now I'm going to do this, and it's going to be really fast. So just breathe with me. So once you initiate and you're starting to pull this, pull fast. Don't take your time. And then he's going to cough and snort and sneeze, so clean him up, and then you're going to wrap this up and put it in the trash can. And I'll wrap it up and throw it away. Okay. Hi, it's Debbie Casa, site coordinator at Amarillo. I have Guy Gilbert, our assistant director of Sim Central, and we were going to talk to you about how to do stoma care. Stoma is where the bowel comes through the stomach. Maybe they had colon cancer or some kind of traumatic effect, and so you can have a stoma just about anywhere. This is a dual stoma. Sometimes we can go back and animose those together and let it heal once the trauma is over with the abdomen. Or if they have colon cancer or some other type of disease process, they may end up with a stoma for the rest of their life, depending on where we put it. This one could be a urostoma, meaning that urine comes out of it, and this one can be from the intestines, which will have stool coming out of it. So anytime you have to change a device or a bag, a stoma bag, you want to take towels and kind of clean up, remove as much as you can around the stoma. I'm looking at the skin. As nurses, we're always assessing and looking at that skin. I'm looking at the stoma. I want a nice beefy red stoma. I want to see if there's any breakdown around my skin, any problems here. I can see it's intact and it looks really good. So I'll put a wet towel over it so that if he has to go, I won't get stool on me. I'll need a wafer. I'll need a bag. I like the Tupperware, meaning that they'll fit together. You can do it all one piecer and do it together, but I prefer the two piecer. It's just, to me, the patient can take it off and clean it out, and they don't have to keep taking off their wafer. Just take off the bag. So the wafers come with a measuring tool, because every stoma is different. So I'm going to measure this stoma. And the closer I can get around the bag or around the stoma, the better. So I want to cut, this one's too tight. That'll impede. I don't want to impede the flow of the stoma. That one's pretty good. So let's do it. It's going to do about that. So I take this and I put it around here. I can draw a circle around. So I'm going to take, and I'm going to circle around that sucker just like that. I'm just going to cut this around, and what I'm doing, I'm just cutting it around here, and I'm getting this ready. Some of these wafers will come with a powder, so I can powder around it. It will help me connect it, or it'll have a stoma paste, and I'll squeeze that around, making sure I'm close to my stoma. I'm not getting it out on the skin. I want it close. Then I'm going to open my ring. It's kind of like a wax ring on a toilet, is what I think. And then I put this around there, and I'm going to fix it into that. That paste will seal up around the stoma. I use my hands. The warmth of my hand in this will adhere to that. And then I'm going to pull this down here, and this is going to adhere to the skin. I want it as clean and dry as I can, as no wrinkles. Now, depending on how my patient, if they're ambulating, or if they're in bed, I may take the bag and go this way. If they're walking, I may do it this way. I ask the patient which way do they prefer, and then as I go around, I will push this on just like Tupperware and kind of work it around. I'm real careful. If this is a new stoma, it's going to hurt as I put this on. And I talk to my patient, and I'm telling them what I'll do. You'll hear it snap. It's snapped into place. It's in place. I want to seal this bag. Now I'll have my patients ask me, oh, it smells so bad. What can I do about that? I don't want that smell. They can put a little bit of mouthwash. Be careful not letting it splash up on the stoma. That burns. Or you can actually put an aspirin tablet down in this bag, and that will help. Who would have thought aspirin will help alleviate? I double this here, but yeah, aspirin helps get rid of that smell, and then I clamp this down. The reason I double it is so I don't have any sneaky liquid falling out, and I push this down and here it clamp, and I make sure it's sealed really good. So that's on, and that's on, and I see how it feels, and I'm always going back and checking, making sure I don't have any stool coming out, ask them how they feel, and make sure everything's okay there. Okay. Hi, I'm Debbie Cassida, site coordinator and Melissa. We're at the Sim Central. Mr. Guy Gilbert's assistant director, and he's helping me videotape this. We're going to talk about collecting a stool sample. You'll need a guayette card, a guayette solution, and then a stick. We'll do this. We'll gather up the poop and put it on the hemocolt card. And what I'm trying to figure out is if this patient is positive for blood in his stool. And so I collect a sample. I can do it out of to put a hat in the commode and collect it, or I can do it here and I put a sample on here and I'll just kind of wipe it on there. And I close this, and then I'll take my card and open it, and it just takes a little bit of a drop. Make sure you're using your orange strips down here, because that's going to tell me what color of blue. And if I see blue on my sample up here, that means I have blood in my stool. This is a positive over here, and this is a negative. See the blue coming through here, and there's blue over here too. So this is called a positive stool sample for blood. And so we possibly have a GI bleed, or it could be hemorrhoids. But once you get this, then the doctor needs to do further testing to see what kind or what is occurring with this patient. So, and nurses need to be proficient in doing this test. I'm Debbie Casta with the MLS site, and I have Guy Gilbert, the Assistant Director, Sim Central. We are here to talk about enemas. Of course, that's a favorite thing the nurses like to do. I've done plenty, let me tell you. So your patient needs to be on the left side. Why would we want our patient on the left side? We want them on their left side. Think about it. So we think about the A and P. You have your ascending colon, your transverse colon, your descending colon, which is on the left side. So if I'm entering my left side, then I'm laying on this side, it's coming on this side, then I get a better wash. Then if I have it this way, then I'm not getting a good wash. So I want to go to the left. That is so important. So a lot of times we'll go ahead and try a suppository. There's glycerin suppositories. We can use these if need be to help. We'll lubricate it. So how do you put a suppository in? It's got a sharp tip and a blunt tip. Which tip goes first? So I learned this when I was a very new RN. Had a drug rep, and I never knew this. They didn't teach me this in nursing school, but it makes perfect sense. The sphincter has lots of rings around it. So when I insert, I put my lubricant and I put the blunt side in and I push it with my finger. As the sphincters close down, around this, see how it pushes it in? But if I do it this way and those sphincters close, it pushes it right out. That's why they make it this way. And it shoots it right in. Saves you a lot of work. So that's how you want to put it. Now, if that doesn't work, the next step will sometimes the doctor says, well, let's do a Fleet's enema. You can buy these over the counter. It is a laxative. They come like this. Most important thing I can tell you, be sure you remove the cap. Yes, people have used these with the caps in, instilled it into the rectum, and then we have to go after it. Be sure the cap is removed, always. It's already pre-lubricated. You just insert it in, you squeeze it all the way down until all your fluid's out. So you just squeeze it real good. Tell them to hold it, hold it, hold it. Very important. Then once they can hold as long as they can, when they have the urge, have a bedside commode or a bedpan ready for them, because they're not going to make it to the bathroom if they've got to go. All right, talk about enemas. Enema, fill this up with warm water. Don't put cold water in there. Warm water, Castile soap, we'll put that in there. We'll fill it up. Sometimes we have the buckets. We'll lubricate this. Make sure this clamp is on or you'll get a bath. I tell my patient, I'm going to instill this in you and I'm going to let the bag run in. Now, the higher I get, the faster the water runs in. The lower I go, the slower the water goes. So I want to be sure that I'm talking to my patient. Hey, I'm going to insert this in, and I'm going to go as far as they'll let me. Sometimes there's such an impaction in there, you can't get it in, but go as far as you can. Hold it, and I hold it, and then I loosen this up, and I let it run. And I'll raise it and I'll say, tell me how you're feeling. Oh, I'm cramping. Slow it down. And then I raise it up. Oh, I'm cramping. But I try to instill as much as I can and ask them to hold it. So once they tell me they can't do it anymore, I clamp it off. I pull this out. And then I help them get to the bathroom. But I like them to hold it as much as possible if they will. So that is just a simple suppository, the fleets, and instilling an enema. One of my favorite, especially with the older generation, they come to the ER, that's the #1 complaint. Can you believe that? Constipation. So we do a lot of enemas in the ER. All my trauma training, I'm an ER, I do enemas. So it's filled up, and I instill this into them. And we call this a back flush or return enema. So with a return enema, back in my day it was a Harris flush, but they're calling it return. So I let it go in. Oh, I can't take it anymore. I put it below the bed and it'll run back out. You'll see stool start breaking away. It's kind of a mining effect. It runs in and it mines it away. So I go back in and let it go. Can't take it anymore, let it come back. And I keep doing this back and forth. Let it all run back out. And it's real brown stool. It comes through here. And your bag will fill up. Your bucket will fill up with poop. And then when you get where your tube just can't take it anymore, then you stop. But eventually by the time you do that about 2 times with a new bucket, they're going. It's a sure thing. It's easier than digging them out with the digital disinfection. So I take this out. Make sure I'm clamped. I don't want a bath. Seems like I always have somebody that can't hold it, and I stand to the side because they'll sure get you, and pull it out. And then I clean them real good, make sure my bedside's commode, make sure the rail's up, call light. Call light's very important. I check on them often because sometimes they just go. Remember, God made you washable, so we can be washed. Okay, that's it.